Carpal tunnel syndrome, symptoms, diagnosis, and treatment from Parkway Neuroscience and Spine Institute. Part 3 of 3.
I know Dr. DeMarco went over a little bit of the anatomy, but very similar to, so you understand the pressure usually is right there at the wrist crease or just distal to the wrist crease, just after it. Tends to control, like Dr. DeMarco said, 3.5 fingers there as far as the sensation, as well as some of the strength that specifically allows you to pinch the two fingers like your thumb and first finger together to pick things up. Sometimes if that motor nerve is damaged, you can't bend the thumb at the end and you end up only able to do this, which makes it difficult to pick things up. In the anatomy, this is the area where it's tight right here. This is the transverse carpal ligament. Typically, when I do the surgery, as Dr. DeMarco said, all these pictures sort of point to it as being right here. In reality, it actually goes pretty far up the hand. Even though we make a small incision, I sometimes have to go fairly high up to release the entire band. And it does go a little bit out toward the hand a little bit more. So it's typically bigger than what the pictures show. This is that cross section Dr. DeMarco talked about. So our incision typically is right here. And we're actually doing is releasing this ligament right here, or cutting that. Then typically that will snap open and then open up this tunnel so that it's 1.5 times the size that it was before. A lot of times we see situations where people, especially people who use their hands a lot, this ligament just gets thick with time. And as that thickens, it makes the tunnel smaller and smaller. So there's several different ways we can do the surgery. Typically, about 1/3 of our patients have only one side. They'll come in, and I don't know if it's Dr. DeMarco's experience, my right hand hurts or my left hand. It's usually not, 1/3 of the cases, it's not both. And of course, cases like that, they'll be sent to me from with a nerve study, typically from Dr. DeMarco, saying that they have carpal tunnel, it's right at the wrist, and then we'll talk about doing surgery on just one side. 1/3 of the patients have symptoms on both sides, and typically they'll have a situation where they'll say, and many times if they're dominant in their right hand, they'll say, my right hand is worse, but my left hand's sort of annoying too, but it's not as bad. One option for surgery for these patients is we do what's called a staggered or a staged procedure. And what we'll do is do one side first, and then 3 weeks later they come back and we'll do the opposite side once they've recovered fairly well from the first side. The advantage is it gives you a little more recovery time, typically 3 weeks for each. Some people do 2 weeks between. The disadvantage of this, especially today, is it tends to be, of course, more expensive. Even though people have insurance, some people have a deductible, and some people it's as high as 40% today. If you have this in 2 different procedures, you have to pay the cost for the anesthesiologist, for the facility, 2 different times. And then, of course, there's a longer return to work. You could also do this, and about 1/3 of the patients will do this both at the same sitting. Do a right, then do the left at the same time. And about 1/3 of the patients elect to do this. And it wasn't possible years ago. I'll go over the actual surgery itself, but years ago with the older techniques, I'll show you they used to use a very, very large incision and a very big puffy dressing on. And it took quite a while to recover, and almost everybody needed therapy afterwards because they had this dressing and the splint on for 3 weeks. And it really took some time just to get that back again before we could even do the opposite side. But we do these minimally invasive today, a very small incision, and you get to use the hands immediately. I'll go over that. I can tell you I've been doing these both at the same time, at the same setting, probably since 1996. And I can count on one hand the number of people who are unhappy with that decision, who said, I should have had one than the other. I really regret doing both. Most people are impressed with how well they bounce back from it. Again, the advantages there, much quicker return to work. Obviously, you're both being done at the same time. Again, one bill. Disadvantages, a little bit of a longer procedure. And some people, again, will say it was a little bit more difficult to recover from. Some people worry that, boy, I don't have help at home. I'm going to have someone do everything for me. It's really not that bad. I'll show you the dressing at the end, but your fingers and thumb are free. I remember I did one of these on a very nice Mennonite lady probably 10 years ago whose hobby was weaving baskets, and she went home that night and weaved me a basket and brought that back to me in her first visit. She did that the first night. That might have been, I'm not suggesting people do that, but you know. Different types of anesthesia this procedure is performed with. There's one type where it's just a local anesthetic only. So in other words, we prep everything, clean it up with a betadine or a special soap, and we would just inject lidocaine or Marcaine or some type of a numbing medicine. We don't use anything to put you to sleep or anything like that. It's just straight local, so you're going to feel, obviously, the needle going in until the hand gets numb. Then typically patients will say, you know, I can feel you working there. It's not sharp, it doesn't hurt, but I can feel you pulling and pushing and things. Very few people opt for this. I may see 4 or 5 people a year that might do that. Sometimes people just don't want the anesthesia. They want to be fully awake, and they just don't like that feeling of being, you know, loss of control. Occasionally I've operated on patients where, believe it or not, even minimal anesthesia is very, very risky. They may have cardiac problems, they may have significant risks, and we just have to do it under local. It's the safest way to do it. But honestly, probably 5 patients a year would fall into that category. What we tend to do at Parkway is what we call, or anesthesiologists will call MAC, or monitored anesthesia care. And this is the twilight sleep. Typically they'll use propofol, which probably for here and ever on will be known as the Michael Jackson drug. There's no point in hiding it. But we tend to do it in a little safer environment than a bedroom. And there's actually an anesthesiologist there, so people bounce back pretty well. People don't recall anything. Sometimes during surgery I'll actually be talking to them. They'll ask me, you know, how many more cases do you have, or we're talking about the weather, and then when we're finished, 15, 20 minutes later, they remember absolutely nothing about the procedure. The anesthesiologist will give you sort of a bigger dose right before I put the numbing medicine in, so they don't remember anything of that, any of the pain at all, really. And then here's typical, propofol is a white medication. Let's put an IV typically on the opposite side where we're doing the surgery. And they'll put that in right before we start. Surgery takes typically, and I'll go over this, maybe 8 to 15 minutes, depending on the patient and depending on how big their hand is. It's typically a pretty quick surgery. Another anesthesia, I've only done a handful of these over the years, and I can't recall the exact situation. This is a little less, somewhere between the propofol, the monitored anesthesia as far as risk, and local. But it's called a beer block. It uses a special tourniquet that we put up high on the arm, and then they actually will put an IV in just on the other side of the tourniquet. After they put the tourniquet up, of course, it stops all the blood flow in the arm. And what they'll do is they'll inject a local anesthesia like lidocaine, and it makes the entire arm numb. Orthopedic surgeons tend to use this more often. It's used a lot of times more often in fractures, sometimes especially with children. It can numb up the entire arm so they can reduce a fracture with a little less pain. But typically I'll have a special tourniquet here. Put an IV typically in the elbow right here, and then we'll do the surgery. And then typically afterwards they let the lidocaine, obviously if they turn the tourniquet down too slow, it's going to go throughout your whole body. They don't use enough that it's a problem, but typically they'll trickle it in very slowly. They'll bring that tourniquet down very slowly. It's a little bit of a longer procedure. It adds more time, but there's really not a distinct advantage unless the anesthesiologist tells me that they want to do it for some reason. Final way that typically it's done, it would be what's called an axillary block. Typically, again, these are performed by the anesthesiologist, but there's a spot in the arm. Dr. DeMarco talked a little bit about the nerves up here, the brachial plexus, which come out through the area under the arm here and go out into the arm. And they'll actually find the spot here where the nerve is. And they'll just actually inject a little bit of lidocaine or numbing medicine up high, and that numbs up the entire arm and lasts for about an hour or so typically. I found a neat picture on the internet I was going to put on this that actually showed one of the doctors doing the axillary block, but it was on a patient who was attacked by a hyena, so I didn't think that would be appropriate because their arm was in. Nothing you'd see around here, so I left that out. As far as the surgical procedure, there's several different types. The traditional approach I mentioned is a bigger incision. I'll show you a couple pictures. One of these is actually intraoperative, but it's not as bad as Dr. DeMarco. So this is a post-op picture. Now, this patient probably had trigger finger procedure as well, so that we wouldn't have anything to do with that. It would just be this incision right here is what they used to do in the old days. Very long incision. This took probably 30 minutes to do. You had to have a huge splint. You'd have to have the arm elevated. You'd have typically some kind of a support for the arm afterwards, a sling, sometimes for weeks. But this is typically when people will say, well, this surgery is much better than the traditional. This is what they're comparing it to. Again, that's just the surgical picture of it, but it is, again, a very, very large incision. The wrist crease is right here. Very rarely is this done anymore. The only time I've seen that done recently would be for tumors or something like that, which is very rare in the carpal tunnel. One type of procedure sometimes you'll hear advertised as an endoscopic procedure. This requires 2 small incisions. They'll always say, well, it's less invasive, it's better than typical carpal tunnel releases. What they're comparing it to, again, is that traditional surgery. The surgery time for these typically is 30 to 40 minutes. It's a lot longer than what I'll show you later is the minimally invasive procedure. There's a greater risk for nerve damage with these, and they will say, they'll advertise that it's an earlier return to work, but again, they're comparing it to that traditional approach, which is true. So typically they'll make 2 small incisions, one out above the wrist here and one out in the palm of the hand, and they use a device that goes between the two, and they use actually a scope to do this. There's a lot less visualization of that nerve, and the incidence of nerve damage is as high as 1 to 2% in some studies. So 1 to 2 out of 100 people will see some damage to the nerve. And that's the downfall of this, plus it takes a lot longer surgically. The procedure that we use is more of a minimally invasive procedure. We make a small incision, about 2 centimeters in length, typically right in the palm here. Also much quicker recovery than that traditional approach. Takes about 8 to 15 minutes per procedure, just depending on the size of your hand. Nerve damage is pretty rare because we can actually see the nerve. We have a very small dressing that's put on there afterwards, but this is a typical incision right here. And what we'll do is use this to access that transverse carpal ligament. But I go in here to see this, and then I have to look upward and cut it up to here and then down into that area here. That's just a window to gain access to that area. We have a self-retaining retractor, so someone doesn't have to hold on either side like this, but this typically does give you an idea. That's about the size of the incision right there. And typically this is all the dressing we use after surgery. See an ACE bandage, and underneath this there's a white dressing. Typically after surgery we'll have you take that ACE bandage off 24 hours later, the next day. That white dressing then comes off typically 3 to 4 days later. At that point you don't need anything on it. You can get it wet. You know, we want you to keep it clean. We don't want you out gardening with it or anything like that without a glove, but you can wash it with soap and water. I typically use non-absorbable sutures. My partners typically use ones that are I use absorbable ones. Ones do not have to come out. They tend to use non-absorbable that have to come out in 10 to 14 days. It's just a personal preference, but I've never had trouble with the absorbable ones. As far as surgical risks, infection always is a risk, and typically it's about in the I'd say the 1% range. A little higher, certain risk factors. If you're diabetic, the risk is going to go up a little bit for infection. Typically, if it does happen, it's a very treatable thing. We put you on an antibiotic. You'll typically see it 10 to 14 days after surgery. You might be doing fine, then all of a sudden it'll be really red. Typically, antibiotics will take care of that. Occasionally, we have to go back in surgically and drain it, wash it out for a few minutes, and close it back up again, but that's pretty rare. There's typical anesthesia risks, again, depending on the type of anesthesia you have. Nerve damage for this for the minimally invasive is pretty rare. Typically, the studies say it's 1 in 12 to 1 in 15,000 I've seen. And what happens, the most common case is that it's that motor branch of the nerve that goes to the thumb that allows you to oppose the thumb. About 1 in 12 to 1 in 15,000 patients have a situation where that nerve travels actually right through the ligament to get to the thumb instead of coming out over the top up here and going around. And unfortunately, the nerve is so small, there's no way to see that until after the ligament is cut. And then we'll notice that patients have trouble pinching like that. When we do both sides at the same time, patients are awake enough with that twilight sleep that I'll actually have them do this on one side to make sure that's working before I do the other side. Because typically if it's an anatomic variation, something you're born with, if you have it on one side, you're going to have it on the other. As far as recovery, we'll tell you to elevate the hand the first 24 hours. You can use ice the first 24 hours. After that, we really want you to resume normal activity with the hand. We don't want you to walk around and protect it. It's okay to get the nerve gliding, Betty Jo talked about, and start to get it moving. Again, take the dressing off completely in about 4 to 5 days. And if you do have sutures that have to come out, it's typically 10 to 14 days. Return to work completely depends on your line of work. If you work at Mack Truck and you're lifting 100 pounds routinely, 50 times a day, it's probably going to be a good 3 months to give you an idea. If you're an accountant, and we did this on a Friday, you could probably go back on Monday. I've actually had people, our office is right down from First Data. I've actually done carpal tunnel surgery on someone in the morning who went back to work that afternoon. Very dedicated. Two of my partners, surgeons get this a lot. Two of my partners have had carpal tunnel releases on 1 week and they were operating the next week, to give you an idea. But again, it depends on what you do. Light duty, we tell people reasonably to expect 3 to 7 days to allow yourself time to recover. You have moderate duty, handling up to 8 to 25 pounds, probably looking at 3 to 6 weeks. And heavy duty, like I said, sometimes up to 3 months, depending on what you do. This is probably one of our more successful surgeries, and I think anyone who does carpal tunnel release will tell you this. I would say easily 95% of patients who have the surgery are happy they did it. If they look back, they'd say, if I had to do it again, I'd make this decision again. Absolutely, I would do it. Most people, in fact, say they waited too long. Usually the 5% who don't see relief or who aren't happy, almost without exception, those are people that simply waited too long. Dr. DeMarco mentioned once about surgery. Even when you get wasting in the hand like that, I will tell patients there's a role for surgery also in getting rid of pain. A lot of times if they have pain too, pain will go away. That strength probably will never come back. The numbness probably definitely won't come back, but the pain may go away. So there's still a role for surgery sometimes. Numbness, that portion of the nerve is the most sensitive part of the nerve, and that's the one that's most difficult to see improvement with. It takes the longest to come back. Most patients who are numb will tell me as a rule, or they'll tell me, the numbness comes and goes. It gets numb at night, but then it goes away at times. Typically, the numbness will go away with surgery. If they come in, though, and tell me, it's been numb for a while, say last month, though, it's been numb all the time. It hasn't gone away. Typically, that's a bad sign. That means that there may have been already some damage to the nerve, and that may not improve. So the key thing is you want to do the conservative things first, but if you see it's not doing better, if it's not working, I don't think surgery is something to be frightened of. It's one of the easiest surgeries we do, and I think it's one of the highest success rates. Thank you.